Welcome to our video series on how to be a good doctor. This is part 2 of ECG interpretation. My name is Dr. Iresha Gunasinghe. I am a consultant cardiologist from California. So, our goal is to teach you to interpret a stat ECG if you are on call in the ER soon after graduating from med school. So let's recap. On the first video, you learned that you have to follow a sequence. And the first thing you have to do when you get an ECG is to look at the rate. Next is rhythm, and then you look at the axis. So the rate you calculate by counting the number of big squares, and I wanted you to memorize this. 300, 150, 100, 75, 60, 50. If the heart rhythm is irregular, you calculate the QRS complexes in 6 seconds and multiply that by 10. Then we talked about the rhythm. Rhythm, you know how to make a decision whether it's regular or irregular. Then we talked about the axis. We look at lead 1, 2, and 3 and decide whether the axis is normal or whether it's left axis or right axis. Today we are going to look at the waveforms, and this video we will focus on the P, PR, and the QRS. So just to remind you, the first wave is called the P, and the PR interval is from the beginning of the P to the beginning of the QRS complex. Okay, so that's PR interval. And then the QRS complex itself. Okay, those are the three we will be discussing. So on a normal EKG, this is the P wave, this tiny little blip, and then you starting with the beginning of the P to the beginning of the Q is the PR interval, and then you have the QRS complex. When we are looking at the P wave, the best place to look at it is lead 2. Okay, that is why in most cases the rhythm strip is usually a lead 2 because it's useful to see the P waves. So the P wave tells us about the two atria, the right atrium and the left atrium, and the only abnormality they can have is they can become big. So if the right atrium becomes big, it becomes tall. Okay, so the way to remember it is when you are right, you feel taller, and the magic number is 2.5 millimeters or more. Okay, so right atrium, if it gets bigger in lead 2, the P wave becomes tall. If the left atrium becomes bigger in the lead 2, it will become broad. So if you are left behind and you eat more ice cream, you will become a little bit more obese. So that's a way to remember that. And remember this magic number, it's more than 3 tiny little squares. Okay. I also want to share these two words because you will come across them. P pulmonale is another way of saying there is right atrial enlargement. And the reason we use that term is right atrial enlargement is usually associated with lung disease. And P mitrale it's like a M, and it's commonly seen when there is left atrial enlargement, and that's commonly secondary to mitral stenosis. So you will hear these two terms as well. And here is a real ECG. So you see this is lead 2, and this one is so tall, right? See that? So when you are right, you feel taller, or we could call it P pulmonale. This is a left atrial enlargement. So when you are left behind, you eat more ice cream and you become a little bit wider. So that's P mitral. The next thing we'll be looking at is the PR interval. And on that, what will happen is it will get longer. So the magic number to remember is 0.12 to 0.21 or 3 to 5 small squares. So on this example, you will see the P starts here, right? So from here to here is a lot longer than 5 squares. So therefore, we say the PR interval is long, and that is first degree AV block. So you learned a new word, which is first degree AV block, and that is if the PR interval is more than 3 to 5 small squares. There is one other condition that is a very common exam question, which is if the PR interval is very short, like here, you can barely see a PR interval, and you also see like a slight unusual curve to the QRS complex beginning, and that's called the delta wave, and this condition is called WPW, Wolff-Parkinson's and White syndrome. So a short PR is seen in WPW, a long PR is seen in first degree AV block. Next, let's look at the QRS complex. There's only two things that can happen. Normally, it is thin and nice, and the magic number there is 3 small squares or 0.12. And the abnormality could be, the first abnormality we'll talk about is if it becomes wider. Remember, the QRS complex starts here, and this whole thing is the QRS complex. So, when it is broad, it could be secondary to what we call left bundle branch block. And what that means is remember the conduction system, the left bundle has stopped working, okay? Or it could be a right bundle branch block, in which case the right bundle has stopped working. And they have unique patterns that you need to know about. So, in this situation, we commonly look at lead 1 and V6. Okay, so if there is a left bundle branch block, what we see is a broad, wide QRS complex in lead 1 and a similar pattern in V6. Let's look at a real EKG. See this? It's broad and tall. So this is lead 1 and this is V6, and you can see the same pattern. See that? Here is another example, a broad ECG with the QRS, which is really broad. But the reason I put that here is sometimes it's not as tall as you would like it to be. But this is the classic picture you have to remember. The next one we will look at is the right bundle branch block. Now in that one, what happens in lead 1 is you have a deep S wave, which is not seen in a normal ECG. And then in V1, we call it the rabbit ear pattern because you have this little M kind of thing there. So let's look at a real ECG. Here you see in lead 1 the deep S. This is classic, okay? A deep S. And on this one, you can see the rabbit ear pattern, but it's not very clear. Well, you can see the rabbit ear pattern, and that's in V1, okay? So that's the way you decide whether when the QRS is wide, you look at the pattern to decide is it a right bundle branch block or is it a left bundle branch block, okay? Now there is one other thing that can happen to the QRS complex, and that is if the left ventricle becomes huge or left ventricular hypertrophy, then what you will see is the voltage goes up. So they become huge. And there are many criteria to diagnose left ventricular hypertrophy. I usually just remember this one for now, okay? So we look at V1. In the V1, you see a deep S, right? The first upward stroke is a little r and a deep S. And then what you do is you count how many squares you have there, and you add that to the the R in V6. Okay, so this is V6 and the tall upward one is R, and you see how many squares it has. Okay, and if it is over 35 millimeters, then we can say the patient has left ventricular hypertrophy. Okay, again, S in V1, R in V6, and you add them together and it should be more than 35 millimeters. Remember, 1 square is 5 millimeters. Okay? So now we know how to quickly look at an ECG and look at the rate. Next, we look at the rhythm. Thirdly, we look at the axis. And then we look at the waveforms one at a time. Okay, first we looked at the P wave, decide whether it's left normal or left atrial enlargement or right atrial enlargement. And next we looked at the PR interval, and then we looked at the QRS, the size and the morphology. So in our next video, we will be looking at the ST and the T wave. So I sincerely hope that one day you'll be a very good doctor and will be able to help people in need without expecting anything in return. And I thank you for listening, and I sincerely wish you the very best. And please do take a moment to share this with your friends.